All right, let's dive straight into a really challenging situation you might face. Picture this. A patient comes in, classic heart attack symptoms, chest pain, troponins going up, the ECG looks like a STEMI. But then they go to the cath lab and surprise, the coronary arteries are completely clear, pristine.
Yeah, that's a real head scratcher clinically.
Exactly. So, okay, let's unpack that. When the cath is clean, you've got to pivot fast. Our mission today is to really get into how vital echocardiography echo is when a pulmonary embolism, a PE, is basically playing dress up as an MI. When your suspicion's high, echo becomes your lifeline right then and there.
It's fascinating because the symptoms are so similar.
Right.
But the cause couldn't be more different. An acute PE just slams the right ventricle, the RV,
Right.
with sudden massive overload.
Right.
So that's where you have to look first on the echo, the RV.
So the visual evidence starts right there.
Yeah.
RV is suddenly pushing against this huge blockage. What does that actually look like on the echo screen?
Well, the RV kind of freaks out. It usually has this nice crescent shape, right? But under acute overload, it gets big, rounder, and frankly, looks weak. It's struggling.
And that pressure, it's so intense it even messes with the left ventricle, the LV.
Yeah.
Tell us about the D sign.
Yeah, absolutely. Think of the septum, that wall between the ventricles, like a flexible partition. The RV pressure gets so high, it just shoves that wall over into the LV space.
Nah.
So during systole, when the heart squeezes, the normally round LV gets flattened on that side. It looks like a capital D in that parasternal short axis view.
Wow. Okay.
That D shape is a huge clue for that sudden right-sided pressure jump.
Okay, let's talk about another really famous one, McConnell sign. It's visually quite dramatic, isn't it? Looks like the RV, well, forgot how to squeeze properly.
It does look striking. What you see specifically is the middle part and the bottom, the basal part, of the RV free wall. They just aren't moving much, or at all.
Okay.
But the very tip, the apex, is still contracting okay. So you get this weird regional dysfunction.
But wait, if it looks that specific, why isn't it a slam dunk for PE? You mentioned we have to be careful with it.
That's the critical point, yeah. It's supportive, definitely raises suspicion, but it's not diagnostic on its own.
Why not? What else looks like that?
Well, unfortunately, chronic pulmonary hypertension can cause a very similar pattern over time. And so can an RV infarction if the patient had a heart attack affecting the right ventricle. Same wall motion abnormality.
Got it. So visual clues are helpful, but we need numbers, measurements. That brings us to the 60-60 sign. What's that about?
Right, we need something more objective. So we look at the tricuspid regurgitation jet, the TR jet velocity, essentially. We measure the pressure gradient.
Okay.
In an acute PE, that gradient is often surprisingly low, usually under 60 millimeters of mercury,
Under 60? Why low?
because the RV hasn't had time to adapt to hypertrophy, to build up the muscle needed to generate really high pressures. It's overwhelmed quickly.
Makes sense.
So you combine that TR gradient under 60 millihg with a pulmonary acceleration time, which reflects how quickly the blood speeds up in the pulmonary artery. That's also short, under 60 milliseconds. That combination, the 60-60, really points towards acute RV pressure overload, not chronic.
And I know some advanced labs can even look deeper, right, with strain imaging.
Exactly. Speckle tracking echocardiography. It's pretty sophisticated. It measures the actual deformation of the heart muscle itself.
How does that help here?
It can pick up subtle RV dysfunction, specifically reduced strain in the free wall. Even if the wall motion looks sort of okay to the naked eye, it catches problems earlier.
So putting it all together, the shapes, the signs, the numbers, how does comparing the RV to the LV help solidify the diagnosis? You mentioned the D sign squashing the LV.
Right. Context is key. If you see that poor RV struggling, looking big and round, and the LV looks small, maybe kind of squashed by that D-shaped septum, that really points towards the RV overload being the primary problem, consistent with PE.
And what if the LV looks normal or even big?
Well, if the LV looks normal or enlarged, you start thinking differently. Maybe the issue isn't purely embolic RV failure. Maybe it's more of a global heart problem or something originating on the left side.
And we always have to remember, echo shows the fallout, not the clot itself.
Precisely. Echo sees the consequences of the PE, the RV strain. It doesn't visualize the embolus directly. That's crucial.
So if the patient is unstable, hypotensive, hypoxic, tachycardic, and the echo shows that RV strain,
Then you often don't have time to wait for, say, a CT angiogram to see the clot. Those echo findings of acute RV dysfunction in an unstable patient are often enough to push for immediate therapy, thrombolysis or whatever's appropriate. The clock is ticking very fast then.
before we wrap, what are the big pitfalls? The things that can really fool the echo or lead you down the wrong path?
Yeah, there are definite traps. Number one is chronic pulmonary hypertension. The patient's RV might already be dilated and dysfunctional, so spotting an acute change on top of that can be really tough.
Okay, what else?
In old RV infarctions, like we mentioned, it can mimic McConnell's sign perfectly. And then there are technical limitations. Poor echo windows, because of obesity or severe lung disease, can just make it hard to see anything clearly.
And small PEs.
Right. Small or subsegmental emboli might not cause enough RV strain to show up on the echo at all, especially if the patient has good baseline heart function. So you get a falsely reassuring echo.
Which brings us right to the big takeaway, doesn't it? Echo is really a rule-in tool here, not so much a rule-out one.
Exactly. If you see multiple signs stacking up, the D sign, maybe McConnell's the 60-60 sign, RV dilation, you should have a very high suspicion for PE and act accordingly. Treat it like PE until proven otherwise.
And this is key. If the echo looks normal, you absolutely cannot exclude PE based on that alone, especially if the clinical story is suspicious.
Cannot exclude it. You still need to consider further testing like CT if you're worried.
So here's something to think about. We know echo sees the consequences, the strain. What happens when a patient already has a condition like chronic pulmonary hypertension that messes up those echo signs baseline? How much higher does your clinical suspicion need to be when those key visual clues from the echo are already muddied? That's definitely something to chew on next time you face one of these really complex diagnostic puzzles.